Well, hello. It's Dr. Matt. I'm a veterinarian and a first-year emergency and critical care resident at North Carolina State University's College of Veterinary Medicine. Nothing I say or do is particularly endorsed by them. We've been having a handful of cases of smoke inhalation, and now that it's winter, like it's coming. So let's see if we can try and knock this out in 20 minutes or less. Okay, so causes, right? So the biggest ones would be building, bush, or wildfires. Other things could be like pets being left in enclosed spaces with cars, lanterns, small fishing huts, anything that you can think of, right? Is possible. It's been shown that 1,000 parts per million or 0.1% of like the air having carbon monoxide in it is lethal. And what to put that practically, or you think about it, essentially it's a cat or a dog being in a single car enclosed garage for 10 minutes with the car on. Okay, so clinical signs. So the most common ones will be kind of smoky odor, burnt hair. They can have like a lot of blinking or just kind of any disruption or irritation of epithelial surfaces. So in physical exams, so generally speaking, you're gonna smell and you're gonna see burnt hair or skin, even the presence of soot. Cherry red mucous membranes, I think, is classically like what students think about when they think about smoke inhalation. However, it's pretty uncommon. Their carboxyhemoglobin levels have to get pretty high in order to see that. So not seeing that doesn't rule it out. And then upper and lower airway stuff, it can cause, again, disruption or irritation of epithelial surfaces. And then neurologic deficits we'll kind of talk about in a little bit. But in people and in dogs, it's like a syndrome called delayed post-hypoxic leukoencephalopathy, which we'll talk about in a little bit. So kind of like four big general things to look out for. Okay, so it's pretty complex, but we kind of broke it down to 7 things that we should be able to knock out in like a couple of minutes. So the pathophysiology of carbon monoxide is that it does rapidly cross the respiratory epithelium and pretty readily binds hemoglobin. Depending on the reference that you see, the affinity for carbon monoxide compared to oxygen for hemoglobin is 200 to 250 times. And then there's something called the Haldane effect. And what that is once carbon monoxide binds to a single site or even just a regular oxygen molecule, it actually increases the affinity of the other 3 binding sites on that hemoglobin to bind oxygen. Problem is with that is offloading to the tissue. Socks are, relatively speaking, an arterial blood gas. But anyway, so there's a decreased stimulation for respiratory drive because, again, the oxygen binding sites are bound. So this is the oxyhemoglobin saturation curve. Kind of 2 different iterations, kind of driving home the same 2 points. So this is the normal line here, like the sigmoidal shape. And as you can see here, that with carboxyhemoglobin, like oxygen saturation is pretty high. The problem is the actual content, because it can't release any, is pretty low. So with cyanide, so this can be produced from the burning of many, many different types of plastic. And just because you see a carbon monoxide doesn't mean you will see a cyanide toxicity, but it's relatively easy, simple to treat. So we'll just talk about it briefly. So it does inhibit cytochrome A3, leading to inhibition of oxidative phosphorylation. So decreased production of ATP, leading to hypoxia and reactive oxygen species. Here's a stylized diagram. So thermal injury, so anything larger than 2.5 millimeters in diameter is going to be lodged up in the upper respiratory mucosa, which is kind of one of its many jobs. And then anything smaller than that usually makes its way down to the lower airways. And with the direct injury or the chemical thermal burn, and then there's the secondary kind of after effects as well. So essentially, there's so many different things and so many different houses, and no house is the same, including the things that are in it. So essentially, like any of these gases and then some, because there's many, many, basically mess with the vasomotor tone. making it harder to achieve homeostasis or keep it in there. And essentially what that does is it goes to worsen in the systemic inflammatory response, VQ mismatch, so on and so forth. So the delayed post-hypoxic leukoencephalopathy, leuko, because it's primarily the white matter. Gray matters can be damaged, but to a lesser extent. And in people, if you MRI them, they have like a pretty characteristic symmetrical lesions that you can see. And it's primarily going to be in the cerebral cortex, the basal nuclei, and then the Purkinje cells. And then acute heart failure. So carbon monoxide does bind myocardial myoglobin pretty quick, pretty easy. And so then what happens there is there's going to be a compensatory increase or further stimulation of the sympathetic nervous system. And then the endocardium of the left ventricle is going to be the most susceptible to hypoxia because it is doing, and so most worker has the highest oxygen demand. And then hypercoagulability. So there's two studies, they'll be on the next slide, that show initially with the systemic inflammatory response, there's going to be consumption of clotting factors and platelets. So initially, what you're going to have is kind of like a hyperactive local coagulation. So whether that be in the cardiovascular system, respiratory, anywhere, but there is an increased risk of thrombosis. And then the next 24 hours, so day 2, they are going to be hypocoagulable. And then about 4 days after, they do return to a relatively unknown, clinically significant, unsure hypercoagulable state. And then these are the two papers. Okay, so figuring it out, right? So these are kind of like the four, I don't want to say mainstays, but I think like pretty basic stuff in order to get a good diagnosis, figure out severity and prognosis, and then some of them actually do also serve to guide treatment, but then are therapeutic in themselves. And then in terms of pulse oximetry, right, it's not the worst tool that we have. However, most pulse oximeters are unable to differentiate carboxyhemoglobin, oxyhemoglobin, so on and so forth from each other. That's the purpose of a co-ox panel or a co-oximeter. So with carbon monoxide poisoning, if you put it on a patient, 9 times out of 10, they're going to have a pretty good SAT reading, right? So a couple things, right? So blood gas. So arterial blood gas is ideal in order to figure out oxygenation status, and also it's going to be better for your co-oximetry. And you can do the PF ratio again to try and figure out, is this patient exhibiting pulmonary insufficiency or the various degrees of ARDS. So again, co-oximetry, essentially what this is it measures different wavelengths, or it kind of, I guess, measures a sample of blood, figures out all those wavelengths. And so then you're able to differentiate the general percentage of the different types of hemoglobin, right? So in terms of an oxygen saturation gap, this is something new that I didn't know about. So if you do get a pulse ox reading, let's say it's, I don't know, 100, right? And then you get a saturated oxygen based on your arterial blood gas, and you do some math and you believe a greater absolute value greater than 5% does kind of coincide with that, but it's usually unnecessary. And then in terms of chest imaging, so up here is kind of a relatively normal dog thorax. And then, as you can see, it can kind of look like whatever it wants. Up here is a relatively normal larynx. So over here, I unfortunately didn't have an image of this, so I did borrow it from the source you see here, but this is a cat larynx that's pretty edematous, secondary to very recent exposure to a house fire. And then these two images here are actually of one of the patients that we had that survived the house burning down. And as you can see, there's just a lot of soot and just kind of nasty stuff. So in order to get a diagnosis, if it's relatively inconclusive, well, also lavaging too helps kind of get rid of that and hopefully speed clearance. So first and foremost, get them out of the fire. Usually by the time they present to you, they've already been removed from the source, right? And then we'll kind of go over most of these, not nutritional support, but essentially they are going to be hypercatabolic. So make sure that once you're able to get them to 100% RER, if you don't initially start with that. If they're metabolically unstable or at risk, make sure you go above 100% RER. So for cyanide toxicity, so you're going to use cobalamin, but it's specifically hydroxycobalamin, and there's actually a human product called cyanokit, which you'll see shortly. This is a precursor to the active vitamin B12, and what it does is ions going to combine with the cyanide to form cyanocobalamin. And if that sounds familiar to you, then yes, right. Cyanocobalamin we use as an injectable for B12 deficiencies of various causes. And then methylene blue and sodium thiosulfate, I usually think of more so kind of like large animal vets using for them. Pretty cheap, but put them on there if you're interested. And then this is the cyano kit that they use in people. Okay, so again, other than getting them out of that fire, essentially you're going to supplement them with oxygen. And there's many, many ways to do it depending on what you have capabilities wise, facilities wise, staff wise, and what you're comfortable with. But essentially, the half life of carbon monoxide in relatively normal animals and people is about 4 hours on room air. But if you put them to 100% O2, it's decreased amazingly down to 1 to 1.5 hours. There's nebulization. There's a paper in children with kind of exposure to house fires and whatnot, alternating nebulized heparin and N-acetylcysteine with each other every 2 hours, and it significantly decreased their mortality, morbidity, and length of hospitalization. And there's a case report later on that you'll see with kind of tracheal cast formation, and this is thought to help decrease that formation. And then bronchodilators, I'm not usually one to jump to those too much, but if they have pretty severe like laryngeal or laryngopharyngeal inflammation, I just kind of treat them similar to a brachycephalic dog, nebulize epinephrine, and usually have pretty good results pretty quickly. So kind of different things. So at NC State, we have the luxury of being able to do all these things. In terms of a nasotracheal line, it's the image that you see that I borrowed from somewhere else. It's the one that you see there's a nasal cannula or a nasopharyngeal cannula, but a nasotracheal line is pretty relatively easy to place. So you just place it under like pretty heavy sedation, and once you kind of feed it and get back the junction of the nasopharynx and the oropharynx, you're going to kind of take it, pull it out similar to an E tube, and then shove it down in the trachea. And then there's high flow, and then in certain circumstances, depending on severity and finances or whatnot, there's mechanical ventilation. In terms of cardiovascular support, so use pressors and inotropes as you see fit. Everyone has different parameters and when they're going to choose and which one they choose and so on and so forth. I found something interesting I've never heard of before called the Parkland formula, and this is essentially with cases that have burns that are greater than their 10% of their total surface body area. You do that math, you replace it with LRS with the first half over 8 hours, and then the second half over a total of 24 hours. And then this was really interesting where they pretty aggressively lavaged some lungs in alive patients. And me reading the study, it was kind of confusing. It said it helped, but then it didn't help. But I don't know, something really cool. Scares me though. Overall prognosis is pretty good. About 90% of them will survive if they don't have severe skin burns, and maybe that's just due as they're less likely to be that critical or unstable or less affected. And then patients that within 2 days after exposure, if their clinical signs have not significantly worsened, they usually have a pretty good prognosis, and most of them will die within 3 days post exposure if they're that severely affected. And then going back to the delayed post-hypoxic leukoencephalopathy is these dogs can have neurologic signs show up anywhere from, 1 day afterwards to several days to weeks later. And people, they saw it as far out as like 240 days post-exposure. And about half of those dogs are going to improve, but not all of them. Not all of them are going to get 100% better. And then, of course, with ARDS, because ARDS is terrible, pretty poor prognosis. Almost all of them are going to die or be euthanized if they're on the vent for more than 24 hours based off a veterinary study that I want to say is recent, but I think it's about 10 years ago. And then in people, it's all over the place. So, like I said, the delayed neuropsychiatric syndrome, which is essentially a synonym for delayed post-hypoxic leukoencephalopathy. If they do develop secondary bronchopneumonia, about two-thirds of those patients will die. Uh, Prophylactic use of antimicrobials is not recommended in smoke inhalation patients, whether it's people or veterinary patients. And then 20% of people will progress to hearts. So there's like a handful of case reports or studies out there about dogs and all the various manifestations they can get following smoke inhalation. But this was the first one back in 2013 that described a patient getting better following like pretty severe progression of disease involving CNS and respiratory. And then this was a case report that I think kind of hammers home alternating nebulizing heparin and N-acetylcysteine, because as you can see with those arrows, it's pretty large tracheal cast or casts that essentially led to a major airway obstruction. So the biggest thing is prevention, right? Just be mindful of your animals. It's hard with cats, right? The amount of times I've seen or heard of cats just kind of slink by and no one else notice. But just being extra careful, make sure you change your carbon monoxide and your fire alarms, batteries at least yearly, and have certain appliances inspected as needed. And then that's the end of it. Hopefully you guys learned some stuff. I think smoke inhalation is super cool because it's a pretty dynamic disease. And then as I'm trying to keep the theme going, is ending these things off with some pictures from residency. So this was my first chest tube in an alive patient. We were a little slow one night, so we played around with one of my coworkers' bunnies. We had a obstructive esophageal bone foreign body that took us almost 3 hours to get out. Hopefully that dog's doing well. She recovered fine, but a little bit worried for her. And then Journal Club, we started back up again, and stats are killing me. So hopefully you enjoyed this, and let me know if there's something different that you want to hear about. Otherwise, thanks a lot, and hey, Happy New Year.